let us go straight over to our guest, shall we, ladies?
Yeah.
Yeah, you ready?
Mm-hmm.
Okay. Well, the topic, like I said, is all about contraception. This is a special NHS program. We're talking about women's health, and we've been doing this for the last few weeks on and off. This is going to be made into a podcast, ladies. So I'm going to ask you to introduce yourselves. So let's start with you, Cindy.
Okay, well, good morning, everybody. So my name is Cindy Farmer. If you ask me to describe myself, I would say first and foremost, I'm a mother. So I've got teenage daughters. I'm a friend. And lastly, I'm a contraception and sexual health doctor. So I'm really looking forward to talking a little bit about my specialist subject, contraception, later on today.
Fantastic. Thank you. Can you beat that, Louise?
I can try. I'm Louise. I'm a nurse practitioner. I've been working in sexual health and contraception for a number of years now. And I've been in Bristol for about 9 years working in this area. I also have 2 daughters. And yes, I would say that, yes, my specialist subjects, definitely contraception and sexual health.
Wonderful. You are both very welcome. So let's launch then. And it has to be the obvious question of all, but the most silly one, I suspect. And it's got to be something around, what is it? So the topic today, contraception. And in our heads, yes, of course, we all know what that is. But I want to go there. What is contraception and why is it important?
So contraception is something that's going to stop you from becoming pregnant. So it does take many forms. So there are hormonal methods. There are barrier methods like condoms, femidoms, diaphragms, that sort of thing. And there's things like natural contraception, which is all down to sort of cycle tracking and various other things as well. But I think the contraception that people mostly think about is the hormonal methods and the copper coil, which is non-hormonal. They are things that the hormonal methods will disrupt your body's own hormones and will usually prevent you from ovulating each month. There are exceptions to this rule, but they prevent you from producing an egg each month, which means that you won't get pregnant. So it allows women to control their fertility and ensure they don't have any unplanned pregnancies, which is really important.
Okay, so we're here on Real Women talking about women's issues. It's women's health. Who's responsible, actually?
Responsible for managing their own contraception. Well, I think we all have to take some responsibility for ourselves. One of the key things about contraception and why I think it's so important is because it allows the individual, it allows you to have a healthy and fulfilling sex life without the worry of getting pregnant. So if you are worried about the risk of pregnancy and you want to have a meaningful, enjoyable sex life, which, by the way, is actually important for your general health overall. You know, we know that having a fulfilled sex life actually contributes to your overall health and well-being. So if you are somebody that you know you want to have sex, you know that there's a risk you could get pregnant, actually, it's important to think about what can we all do to stop that from happening so that we can enjoy sex without the fear of getting pregnant.
What I would like to add is that I think the burden for contraception often falls on the person who can get pregnant, but I think everybody has the responsibility to use contraception. So, you know, unfortunately for men at the moment, the only method available is the barrier method, the condom. But I think, you know, people should take responsibility to use what is available, and hopefully in the future, things will get better for men. There'll be more options.
All right. Well, we do want to talk about the various methods, but because you've already started the topic, I want to ask about how reliable they are. Who wants to go there?
So it's like, well, how long is a piece of string? And actually, it partly depends on which method of contraception we are talking about. So we talk about highly effective forms of long-acting reversible contraception. So that's things like coils, intrauterine devices, implants, injections potentially. And we know that those methods, those long-acting reversible contraception methods, which are sometimes called LARC methods in our world, they have an extremely low failure rate. They're extremely effective methods, and they have failure rates of less than about 1 in 1,000. So they are methods that you can rely on without the risk of falling pregnant. However, failure does not necessarily just mean risk of pregnancy. To some people, a method failing is if you develop side effects or symptoms as a result of that method that actually don't marry or align with what you want out of that method. So although we can talk about the best methods, in inverted commas, being the most effective, actually to real people, to real women, that's not necessarily going to be what's best for them. It's going to be, well, what allows me to live my life in a way that I'm not getting side effects that interfere with my daily functioning.
So when you talk about side effects, what are you talking about? What does that look like?
So probably one of the biggest side effects is impact on bleeding, or that's one of the biggest changes that people report. So bleeding can stop, bleeding can become heavier, bleeding can become a little bit erratic, and that's often quite a big game changer for people. But actually, it's different for different people when we talk about side effects. And that's why it's so important to sit somebody down and say, what is important to you? What side effects are really going to be important for you? And we can work together to find a method that's suitable. Lou, what did you want to...
I think there's sort of very many different side effects as well. And it's worth sort of bearing in mind that kind of, different methods will affect people in different ways. So, what will be, so Cindy might try something and get lots of side effects from which aren't acceptable for her. I might go on the same method and be absolutely fine with it. But that is what the sort of failure is with that, is that if its side effects are not acceptable to the person taking it.
Okay. Well, there's so much to unpack. And before we just bring in everybody to the conversation, just got one more question to ask. And that's about, and you started it, you spoke about coils, you spoke about cup plants. Now, I guess there are terms that I've heard of, but I want to explore. I mean, what does that mean? What does that look like for a woman? And even the names, cup plants, it's like, what? Are you talking about contraception? Can you describe the different types of contraception there are, including coils and cup plants?
I probably didn't pronounce it quite correctly, Sherrie. It's actually implants, not cup plants. So apologies, that was probably me talking too quickly.
No,
then.
don't worry. Okay, implants.
So implants. So we've got implants. So an implant is we often describe it as like a matchstick in size, but unlike a matchstick, it's actually very bendy and very flexible. And actually, that's important that we make that point, because we are actually guilty in the medical profession of often talking about the implant as being like a matchstick, that people often think when it's in their arm that it is this rigid device. And I actually had a patient that came in to see me one time worried that her implant was broken because she could bend it in her arm. And she said, well, no, it can't be bendable because it's a matchstick. So I spent a bit of time saying, oh, I'm really sorry, but actually I think you've been misled. And actually the implant is bendy. It's not broken. In fact, I'd be more concerned if it was fixed and rigid in your arm. But the way that the implant works is it's sited just underneath the skin in your non-dominant arm, typically, and it releases a hormone very, very gradually over 3 years. And the way that hormone works is it stops your ovaries from releasing an egg. So it stops the egg from being produced. And therefore, there's nothing for the sperm to fertilize. And therefore, there's nothing to get you pregnant, if that makes sense. Right, yes. So that's the implant. And then we have the coils. Right. So some people don't like the term coil because actually they don't look like coils. They're often T-shaped devices. And the correct term for them is intrauterine device or intrauterine contraception.
Doesn't roll off the tongue. So
Which
it doesn't, does it?
Which is why we do often say coil. But that's the correct term, IUD or IUS sometimes. And they, as I say, are T-shaped devices. And you can either get non-hormonal versions of those, which contain copper, or you can get hormone-releasing versions, which release a hormone called levonorgestrel. And the sort of device that maybe people have heard of is Mirena or Kylena or Jadess or Levocert, that sort of thing.
Wow. When I hear of coil, it sounds painful.
They can be uncomfortable to have them fitted. I don't think anyone's going to deny that. So they can be uncomfortable to have them fitted. But once they are in, they are a long-acting method, which means that you've got a method in place for, depending on which one you have fitted, it can be up to 10 years, which is going to be over 99% effective. So, they are, yes, I think the initial bit can be uncomfortable, but the way I always look at it is it's far less uncomfortable than giving birth.
Yeah.
And can I just come in as well? So I've been fitting coils now for 18 years. I've got a coil myself. I'd hope you don't mind me sharing that. And actually, I have to say that when I had my coil fitted, I experienced maybe 3 seconds of discomfort, and that was it. And it was not at all, and it was a difficult coil fit, I have to say. So the person that was fitting it said, "Oh, it's a bit tricky getting it in past your cervix, Cindy." But actually, in spite of all that, I promise you, I did not experience much in the way of pain at all. And I think that's a myth, if we're allowed to debunk myths. That's a myth I'd like to try and dispel, the thought that actually coils are going to be painful. I don't want to diminish people's experiences, because I know that people do report pain when they have coil fittings, but I think that's the minority. I think actually people who have perfectly sort of insignificant coil experiences, if you will, because then they haven't experienced any pain, and it's just been a simple, straightforward procedure, don't often talk about it because it's not newsworthy. So they just keep it to themselves and they say, okay, yes, I've had a coil, I don't need to tell anyone about it. And we only tend to hear the stories when people have had a terrible experience that they feel they need to share with others. But actually, as I say, I think they're not in the majority. I think most people find coil fittings reasonably straightforward.
Okay.
It's worth bearing in mind that in England, we love to moan about things. So, if people have had a bad experience, God, we love to tell everyone about it. But you don't ever go to the pub and sit down and go, God, I had a coil fit today and it was fantastic.
It was great. Yeah.
It's just worth bearing that in mind.
Fair enough. No, absolutely. Okay. Other methods.
I was just going to say, what's the sort of percentage of women today that have coils as opposed to other contraceptives?
So the figures are increasing. So NICE, NICE is the National Institute for Clinical Health and Excellence, and they first produced some guidance for the medical profession talking about contraception. When they first produced that guidance, sort of about 19 years ago now, only about 8% of the population were using what we call long-acting reversible methods. That figure has now come up to around about 20 to 25%. So more and more people are turning to these longer-acting methods. And you might sometimes hear them referred to as user-independent methods as opposed to user-dependent methods, which is a bit of a mouthful. But what we're essentially discriminating between are the oral methods or the pills, which require somebody to remember to take them every day. Hence, they're user-dependent, because actually their effectiveness relies on how good that person is at remembering to take a pill. Versus the user-independent methods, which are sometimes called fit and forget methods. So once they're fitted, it doesn't rely on that person to remember to have to do anything in order for that method to become effective. So as I say, increasingly we're seeing more and more people turning towards those user-independent methods.
Okay. Julie.
Hello. So I kind of did a little bit of research last night and I was a bit intrigued by what I found. So to me, it's swinging 60s. It's everybody on the pill. Not so. So in this country, it came out in 1961 and I think it was only married women. And it was also married women that people felt possibly shouldn't have any more children. So I can remember Mum and other people of her generation actually having quite problems accessing the pill. Because if your GP wasn't in agreement that your family had finished, you wouldn't be given access to it. And it kind of surprised me that it wasn't to 71 that you could go to family planning clinics as a single person and access it. And I think I'm sort of, everybody's on it. Everybody has got contraception. But is that true? Are there barriers culturally, religious, or perhaps fearful, or people with medical history? Maybe they've had DVTs, or maybe their weight doesn't fit the category where it's safe to take them. So are a lot of people still having access problems?
I'm going to say yes. I think obviously it's things have changed, and if you look back to the history of contraception, what it has given us is freedom as women. It's given us control over our own fertility, which is really important. And I think it has changed a lot of things for women, hugely for the better. I think a lot of people now don't remember actually what things were like back when it started, and having to have sort of a letter from your husband to say he was happy for you to have a coil fitted, etc., etc. And I think what I found is there has been a certain amount of backlash towards contraception. You see things in the media about people saying your body is flooded with hormones and these sort of raging side effects. And it's just not very representative of actually what contraception is and what it does to you. So I think one of the barriers we see is how contraception is now portrayed as being something, possibly quite negative, which puts people off, which is a really sad thing. There's also sort of barriers around, sort of societal norms. So, if people say, my sister, my mother have tried this method and they don't like it, so therefore I don't want to try it because I won't like it as well. People have these sort of, word of mouth problems around sort of, people saying they don't like methods. But as I said, in this country, we do love to moan about things. We don't like to say when they're really good. And there are cultural issues as well. I think there are a lot of people from cultures and communities who will struggle to access mainstream healthcare. And that's quite often in the past, they may not have been treated particularly well by mainstream healthcare. And we do think that is an issue from the past. But if you look at, the current climate, for example, Black women are 3 to 4 times more likely to die while pregnant or, in childbirth than white women are in this country. So it's still a very, very current problem that people don't feel they are treated as they should be by the health services. And that does create a real barrier. And then if you're looking at things about the way that contraception affects you, for a lot of women, the idea of not having a period is like the best thing ever. I know that my pill stops my periods, and God, there's no way you're going to take me off that pill because I love it. But for a lot of women, actually, it's really, really important. They do have that monthly bleed, and it's a regular bleed, and they know when it's going to come, because that is something that for them, they feel is very important, and they don't want to go on contraception because they don't want to stop that. Cindy, do you want to jump in?
Yeah, no, just on the point that you made about societal norms and what is and isn't acceptable to society, that definitely can present a barrier for a lot of people. And actually, Jean, you were talking about the research that you'd done. And actually, when the pill was first introduced, the way in which we taught people to take it was to take it for 3 weeks, take a pill, and then have a week break. And during that week break, you'd have a bleed. That bleed actually isn't medically necessary. The reason why they introduced that bleed was so that people who were on contraception could appear to be normal, in inverted commas, and mask the fact that they were on contraception. And that was to make it more aligned with the teachings of religion at the time. I'm sad to say, though, that often societal norms do still play a role in putting barriers up for people taking contraception now. And we increasingly see that things that are kind of spread, misconceptions, myths around, can abound and can very much influence what somebody uses when it comes to contraception. So definitely that's still in play at the moment.
And age. So is there still a responsibility with the GP if they've got a 14-year-old, for example? Does mum and dad need to know before you can prescribe that? Are there some rules and regulations?
There very much are rules and regulations that govern our practice. So we don't have a lower age limit per se. We know that obviously the age of consent is 16 in the UK, but we can see people under the age of 16 as long as we make a thorough assessment that they are competent, that they understand the information that we are giving them, that giving them a method of contraception is in their best interests, that they cannot be persuaded to tell their parents about that visit, and that they would come to some harm if we were denying them that method of contraception. If we can fulfill those criteria, which are sometimes called Fraser competence, then we can supply contraception to that young person without informing their parent. Obviously, whenever we see any young person, we do safeguards in place, and maybe Lou, who's our safeguarding nurse, might want to talk a little bit more about that.
So we work with a structure called Spotting the Signs, which was developed by the NSPCC. And that means that for all young people, there are additional questions that we ask and things that we think about. And it's not just related to their sex life, it's related to their home life, to school, to what's going on with them. We look at things like risk of child sexual exploitation, drug use, mental health, all these things. We work very closely with, social care. If young people are under social care, we work very closely with them. We sort of talk to GPs, that sort of thing. So we won't just see people in a vacuum. If we do consider that information needs to be shared, then we do ensure that it's shared properly. But it won't be that if a young person comes in to see us, that information will automatically be shared by their parents. Because unfortunately, for some young people, that might be a risk for them, that, they can't tell their parents because of whatever reason. That might not be safe for them. So we need to ensure that young people are safe and they are cared for to the best of our ability, which we do take very seriously.
dancing here in the studio. We're talking about contraception. We have two healthcare professionals, Louise Bebbington, the sexual health nurse, and also Cindy Farmer, who is a doctor. Great conversation. I mean, this is an education as well for us, but we're going to continue the conversations. We're going to start now with myths. You both mentioned about myth busting. Let's continue on that vein for a moment. What are the myths that you know of?
There are so many.
Really?
So many. One of the things that I sort of just touched on earlier was you sort of see this idea now that sort of being on hormone or artificial hormones kind of floods your body with hormones, and it's really not the case. They're not how they work. They actually just sort of the hormones that are in contraception are artificial versions of hormones that we produce ourselves, and they kind of the way I always think of it is they kind of just pop your body into a point where it's not fertile, and they kind of keep you in this very steady state. Obviously, yes, people do sometimes respond badly to that, but for lots of people, they don't have any issues with them at all. And it's not sort of flooding your body with this huge amount of hormones. It really is just to kind of keep it in a sort of steady state.
Yeah.
But one of the things that I think these ideas, recent ideas around contraception have possibly caused, or possibly, I'm not sure what the sort of relationship is, but there are these new apps for contraception. Quite often people will use like a cycle tracker, which isn't really marketed as contraception, but they'll use a cycle tracker because it'll tell them when they're fertile and they avoid sex around that time. And there are other apps which are marketed as a method of contraception. I don't know if I'm allowed to say names.
Well, there's only one that's
Yes.
licensed at the moment, and that's Natural Cycles.
So it is licensed as a method of contraception. It makes me quite nervous as a contraception nurse when I know that somebody is using that as a method, because natural family planning is very much a thing, and it does work, but it takes quite a long time to learn how to do natural family planning. It's quite a convoluted process, and the apps kind of tap into little bits of that, but for me, I'm not entirely sure they sort of cover everything. And I know they do work for some people, but I don't feel they are as effective as the sort of more traditional kind of methods of contraception that we have.
Yeah, and if I can just come in with that, I think what's important to realize is that as you say, Lou, there are lots and lots of apps that are available, but only one is specifically licensed for contraception. Now, the reason that's significant is because that one method is subject to the regulations of the MHRA, which is the Medicines and Healthcare Regulatory Authority, which is the authority that gives all medicines in the UK a license. Apps that aren't regulated by the MHRA are therefore not subject to the same stringent rules, which means they can make claims that aren't necessarily substantiated. And some of you might say, well, hang on a minute, what about advertising standards and that? Well, the Advertising Standards Agency will actually only respond to complaints made about a product. It won't proactively look at the information that's been put out by the company. So if someone were to complain about the claims made by some of these other apps, then yes, the Advertising Standards Agency could intervene, but unless somebody does, they don't. And I think the other thing to just be aware with an increasing use of apps is that people just need to be aware what happens to their data. So because often these apps require you to input when your period was, where in your cycle you are, which is a lot of very personal information, and what happens to that data. And some people might say, well, I don't really care what happens to that. But actually, I think we have had some worrying reports about what's happened in the States, in the US, around the use of that data and reproductive coercion control around access to abortion and things like that. So there are implications around people high up in authority having access to your intimate data.
Wow. Okay. Yes.
And I think also, with using like a contraceptive app, people need to have a really good understanding of if you're not using it correctly, then what happens next? It's very easy to take a pill every day. It's very easy to have an implant fitted, but actually using the app takes quite a bit more effort. So people need to know what happens if things do go wrong, where they need to go, we're thinking about sort of things like emergency contraception, things like that. And, quite often people might not have that knowledge of when they might need to take the emergency contraception. And so that's all something that is quite important as well.
And on the whole, who are the women who opt for the natural method, for want of a better term? I know you've used another term. Could it be religious reasons or?
I think it's people
cultural reasons.
People who worry about the effects of hormones primarily, and these are concerns that are shared quite widely on social media, for example. And the information that is being put out there is not always completely accurate, and that is, I think, where the issue is mainly coming from. Is that there are a lot of myths around the risks associated with these hormones, and that is shared in ways that perhaps is not as accurate as we would like it to be.
Okay.
Yeah. And one of those myths, isn't it, is that people worry if they're on hormonal contraception for a long time that it will impact on their future fertility or render them completely unable to get pregnant again. And that is not supported by the evidence or the literature. So there is one method of contraception, and that's the injectable contraceptive method, that is associated in a delay of return to fertility. But all the other methods are not associated with any delay in return to fertility. And so we feel that those do not impact on your long-term chances of getting pregnant. But certainly that is a myth that's abounded quite a bit.
And I think sometimes, people have problems with fertility and they might have been on contraception for a long time and they automatically put those things together and think that they're linked. They're probably not. It's probably just actually you were on contraception for a long time and unfortunately you're now having problems with fertility. It doesn't actually mean the two things were linked at all.
Right. And is it true that some contraceptions, like the pill, for example, can put weight on you?
It doesn't make you fat, it makes you hungry. So, yes. So this is what it is it puts you at, I always think of it puts you at this point in your cycle. So for some people before their period, they might feel like they just want to eat everything.
Especially chocolate.
Precisely. And for some people, they go on contraception and it just puts them in this point where they're just hungry. And it's quite difficult because, you'll be kind of snacking. And I think if you don't know that that's how it's working, then it's quite easy actually to start putting weight on because you're not really thinking about it. So I think it's just something that people should be aware of. And if people are on a method of contraception, they do find they're putting on weight, come back to the clinic, have a chat and, have a look at what other options there are because there are so many other options. And, generally, we're likely to find a method that suits people. And even with the pills, there's just so many different versions of the pills. They all work slightly differently. So you might be on one pill and it has this thing where you find, you're getting a bit hungry and you're putting lots of weight on, but you could try a different type of pill and maybe that'll be better. So yeah, it's worth just sort of seeing how you go with things. Yeah. Don't put up with things that you don't like, but always come back and talk about your options.
It really does sound like there's so much out there. If women wanted to find out more, obviously they would go to their doctor. That's the first port of call, I'm sure. Are there any other organisations that people can contact?
Yes, so there are some really good websites out there that have got really good patient-centred information. So Contraception Choices is a good website. And what's great about that particular website is that they have a tool that people can kind of interact with to try and find what's right for them. So it's a sort of a sophisticated online questionnaire, I suppose, if you will, where you kind of put in your hard nose, what you would be willing to tolerate, what's acceptable, what do you want out of your method. And then it kind of narrows it down to sort of 3 or 4 methods that you might want to consider in the first instance. So that's Contraception Choices. Brooke have a similar tool on their website as well. And again, lists out all the different methods of contraception that are available to them. There's also other tools like, there's a website called The Lowdown, which has a missed pill calculator. So for somebody that's already on contraceptive pill, but they miss a pill and don't know whether they need to use emergency contraception or whether it's fine, there's a simple calculator tool that allows you to work out what is and isn't needed.
The Lowdown also do user reviews. So women will go on to the Lowdown and put on what their experience are of certain methods, which is really great because you can really see how sort of it affects real women's day-to-day use.
You say about being able to calculate if you've missed. How effective would the morning after pill be? And is that something that you as practitioners would promote?
So we definitely talk about emergency contraception to people. And actually, yes, missed pills and then having sex in the time when you should perhaps be not having sex after a missed pill would definitely be an indication for thinking about emergency contraception. Now, there are 2 types of oral emergency contraception available. And actually, one of those types you shouldn't take if you have missed a pill because they can interact. So the 2 hormones in the 2 different types of pill can interact. So the true forms, just so that we know what we're talking about. So there's something called ulipristal acetate, which is a form of oral emergency contraception. That's the one that you shouldn't use if you have recently been taking another form of hormonal contraception because they cancel each other out. So if you are in that missed pill situation and you've identified that you've had unprotected sex when you should have been abstaining perhaps and you need emergency contraception, the one to take is something called levonorgestrel. The issue with levonorgestrel as a form of oral emergency contraception is that you need to know your weight and your BMI, because if you're above a certain weight, if you're above 70 kilos or your BMI is more than 26, you need a double dose. And that's something that people don't always realize. So those are the two oral methods. However, there is a third form of emergency contraception, which is the coil, the copper intrauterine device. So it doesn't contain any hormones. And actually, that method can be fitted up to 5 days after unprotected sex, or perhaps even later on, if we can calculate where somebody is in their cycle and we can confidently predict when they would have ovulated. So it buys you a bit more time.
Wow. Well, listen, we are coming towards the end of our conversation and it has been a fascinating one. Thank you so much. But we do want to end with Julie's question regarding men.
So it's interesting. I think you did hit on responsibility. Yeah. And it often comes down to the woman because she's the one that's going to get pregnant. But I was thinking and overhearing conversations in my family, and men have often been really involved in the decision making about what works best for them and their partner, be it their health, be it we've finished our family, let's have a more permanent solution that's easier for the male rather than for the woman. And I know some of the men in the family have undergone vasectomies because for them, their partners don't need to worry about all these hormones, contraceptions, things not working. So I'd like to honour the men who are standing out and making decisions and being part of this process rather than not having anything to do with it.
I think that is really important. And yeah, I love it when men get involved and actually take the responsibility as well, because it is everyone's responsibility. Yeah,
absolutely. Well, listen, it's our responsibility now to say thank you to both of you for coming into the studio to talk to us. It really has been fascinating. You're always welcome to come back, and I'm sure there's going to be a lot of response from this conversation. It's going to be a great podcast. Can I just thank Louise Bebbington, sexual health nurse, and also Dr. Cindy Farmer. Thank you.
Thank you for having us. Yeah.